Started. Thank you. And good morning, everyone, and welcome to the Navigating Documentation Requirements for the Peer Provider webinar. So excited to see all of you on the call today. I'm Yvette Kelly, one of the co-directors of the Peer Support Services Technical Assistance Center. And today I'm joined by several of my colleagues from Peer Tech, one of which is Maria Fuentes. And we'll talk, I'll give you a little brief introduction momentarily. But for those of you who are not familiar with myself, let me move my slide here. For those of you who are not familiar with myself, I'm a licensed mental health counselor and spent my career working with children and families. And one of my primary roles was overseeing a children's behavioral health clinic. And in that role, I really came to understand documentation requirements as it relates to delivering services in Medicaid billable environment. And so we're going to kind of utilize that expertise to walk you through our presentation today. As I mentioned, I'm also joined by my colleague, Maria Fuentes, who is a credentialed family peer advocate and also has experience working as a peer provider in an outpatient mental health setting. And so hopefully you'll find today's presentation helpful and really will just really be supportive in laying the foundation in terms of documenting in a Medicaid service billable environment. Before we move forward, just a few things in housekeeping. We're going to ask if you are not muted up on entry that you do so, just to make sure that we avoid any background noise during the presentation. We are going to have a couple minutes for questions at the end of today's presentation. However, we're going to encourage you to submit your questions throughout the presentation utilizing the chat function. Again, as I mentioned, I have a number of colleagues on the call who's able to kind of review and field those questions. And if need be, I could take questions along the way as well. Live and closed captioning is available should you need that. You should refer to your navigation bar at the bottom of your screen and you should be able to access that. And then lastly, the webinar and the slides and the recording from today will be made available after our presentation. Usually takes us a couple days, but it will be posted to our website, peertac.org. So again, going to encourage you to check us out if you haven't already. There's a lot of great, not only will this presentation be there, but there's also a lot of other great information that you can access. All right, so here is our agenda for today. So Maria and I are going to spend some time covering the following topics. So we're going to start by really just reviewing the importance of accurate and timely documentation and the mental health service delivery space. We're going to detail kind of what information is necessary for specifically Medicaid billable progress notes and as that contributes to the record. We're also going to speak to how the core principles of peer support really get represented in documentation, and then talk through some strategies to support effective documentation practices. All right, so I'm going to just kind of give my little disclaimer about today's presentation is going to be, chock full of some great foundational information. But you won't walk away from today's presentation knowing how to do this immediately. Like, documentation is a skill that requires practice, but what you will walk away with from today is just understanding some of the foundational elements as it relates to documentation, again, in a Medicaid billable environment, and things that you will need to know. And we're going to kind of try to connect some of the dots for you. We also have a number of other resources that are available, and I believe we link to them at the end of today's presentation that really can support providers, all types of providers, by the way, but learn some of those foundational concepts and practice those. And what we have done previously, which is our documentation done right workbook series. Some of you may be familiar, some of you may not, but there's a lot of skills and some of the concepts that we explore here will be explored in more detail there. So Again, happy that all of you are on the call today. So one of the things that we always like to do is just to know a little bit about the audience that has joined us. So we're gonna ask you to complete a poll. We're gonna launch a poll. You should see it. There it goes. Come up, and if you could just take a moment to just identify in what capacity you're joining us today. In part, it's again helpful for us to know who's on the call, but also, as we create resources, we want to know and tailor resources for audiences and kind of understand what the need is. So we'll give you a couple more seconds and you'll be able to let us know who's joined us. Great. I think we have some are still participating. Great. We're waiting for a couple more responses. All right. I think it's going to be, oh, people are still responding. So we'll give folks just another couple of seconds. Great. All right, I'm gonna end this poll. Um, and so here are our results. You should be able to see them. So great. So it looks like we have a lot of peer specialists and advocates on the call. That's great because really this conversation is to really support peer support delivery and documentation. So that's great. We have folks on the call, good majority. We also have looks like a few non-peer staff. That's great, learning more about the documentation and definitely from the peer perspective. Supervisors, which is great because what we know about documentation is that it really does require the support of a supervisor to help staff learn the essential skills. And we have a couple clinic directors or managers and then others. And for the others, if you could just quickly put in the chat what the other is, that would be helpful for us as well if you're comfortable doing that. And just let us know your title so we kind of know who's joining us. All right. And so thank you all for responding. And then we have one more other poll that we want to know as a question around like what are some of the challenges that you've experienced as it relates to documentation? And so we're going to put that poll up for you to respond as well. And as I mentioned before, we are in the process of building out a number of resources around peer support documentation. And so this question will actually help us understand what the need is. And we've gotten feedback and we've heard, and because we've been doing training on documentation a while, we hear stuff from the field, but it's always good for us to kind of just do a check-in to see what people are really struggling with so that when we craft resources, we're able to attend to that need. So if you could just take a moment and just let us know in what ways are you, are you experiencing challenges as it relates to documentation? Perfect. And just a reminder that if you're just joining us, if you're just getting yourself logged in, if you could just mute yourself, that will be great. I see there's a couple other folks who've joined us since the beginning, and while we're waiting for folks to complete the poll, just to say that we will devote some time to Q&A. So if you're just joining us, please feel free to put your, to chat in your questions along the way. Given folks. So again, we're asking the group, what challenges have you experienced as it relates to documentation? All right, I think we got a pretty good sampling. Maybe there's a couple others respond. We'll give another couple seconds and then we'll launch into the presentation. Okay, so I'm going to end this poll. I'm going to share the results. All right, so here's what you guys told us. So time, yeah, time ends up being a big factor, and just being able to meet the documentation requirements. That's nothing new. We've heard that time and time again. Maybe at the end, we can talk through some strategies that may be helpful for that. Lack of training on documentation standards within the organization. Again, that's an area that we've heard sometimes around just not, folks not receiving. I think the assumption is sometimes people come to the work knowing what they should document. And so maybe there's not necessarily a high priority focus on that. um, and sometimes even despite being trained, there sometimes can still be a lack of clarity around what should be included, and like progress notes, and what shouldn't be included, what's too much, what's too little, what's important. And so that we've heard that before as well. Crafting goals and objectives, that's it's one of the ones where sometimes this is depending on the provider type. This could be a bigger deal. Seems like it's not so much an issue here. But then linking progress notes to goals and objectives. And as you hear from the presentation today, we'll talk about how that's important in a clinic environment. And so, but it doesn't. It seems like that maybe is not at the top of people's list in terms of challenges. But thank you all. And I see that no one really has responded other, but if you have some other as challenges that you'd like us to be aware of, please chat those in as well. All right. Okay, so I am going to stop sharing this poll, and we are going to move to the next presentation. I think I skipped a slide, so apologies. All right. So one of the things that I think is important to understand is that when we're talking about um, documentation, right, we're talking about the record. And we're really going to start this presentation today by orienting everyone to some general principles as it relates to documentation, right, in the field of behavioral health. So let me say, none of these principles are new. You've probably heard these time and time again, but it really does set the stage for why we want to talk about documentation as an essential component of care. So, as a helping professional, part of the role and responsibilities is providing in providing quality services really includes properly documenting in the record. So it is part of service provision. It is part of the role. And in this field, you really can't do one without the other, right? So it's important that we learn kind of good documentation practices and habits early, because really at any time a record must be ready for inspection, and it could be ready for inspection by a number of entities, and we'll talk a little bit more about who those entities might be. In terms of expectations around documentation, right? So there are several expectations that are really integral in the role of a helping professional. And this really includes like maintaining high quality documentation related to the services the agency is contracted to and subsequently provides. And so while the agency is responsible for the upkeep and maintenance of the record, it is expected that the individual and family have an active role in contributing to its content, and this should be evident in the record, right? So that should be something that comes front and center in the record. Um, the costs related to documenting service provision is generally, I say generally, included and factored into the administrative cost for the agency. So the expectation is that you're providing the service, that with that service comes the provider documenting what they did. And so knowing what and how to document is really the key to being efficient in this task and practice. And again, like as I mentioned before, documentation is something that needs to be practiced, right? You don't necessarily come to the table knowing all of what needs to be in the documentation in a way that supports kind of medical necessity. And we'll talk through that term. But definitely, this is an area that folks have to put some time and attention to. For this discussion, it's important to understand what is meant by the record. And so here's really just a brief description of what it is. So the record really refers to the record of care, the treatment or services provided to an individual or family by behavioral health service agencies. A number of professionals contribute to the record, and this will include peer support providers in clinic settings. Documentation for the record should really be completed on a regular basis and completed timely to avoid any delays in care, treatment, or services, and that the services are documented when they are provided, whether that be in person, virtually, at home or in the community. And so that's just, again, just some level setting in terms of when we're talking about the record. And so why does it matter? I think one of the things that I always like to talk about is just this, the need to continuously stress how important documentation is to our work, right? As helping professionals, we need to really learn to value documentation as a representation of the therapeutic process it represents, and not just something that's really seen as an unrelated mundane task, right? We're just not doing it for the sake of doing it, but really doing it to substantiate quality service provision, right? And to provide a roadmap of care and to confirm that the care provided is what has been assessed and all of that stuff. So when we learn to value this process, we understand that documentation really serves valuable purposes to our work. And there's several of them, right? So being a vehicle by which providers communicate, acting as a repository for where the individual and family's needs, their services, and their progress is recorded, providing the basis for reimbursement, that is one of the areas. And again, overall, just substantiating all of the hard work done by providers. And I think that's important to say, that the documentation really details how hard the provider has been working with the individual and the family to really assist them in meeting their goal areas. And so you want that to be as accurate as possible. And so again, it's also, if you're a supervisor on the call, it is also the supervisor's role to really relay and reinforce the importance to supervisees around documentation, but also to provide the mechanism in supporting them in learning these skills and how to do it in a way that is not overwhelming and overbearing to the work that they're doing, right? And so being able to talk with folks around that and to really help them understand the purposes of their hard work, right? And how that gets displayed in documentation. Okay. The next thing is to think about when service providers really fail to document and really the impact that that has. And it's, you can see it here from it's threefold, but when providers fail to document appropriately, they're really actually depriving individuals and families of the ability to access necessary information when needed. And just to say that you can never know or anticipate when an individual or family will need access to pertinent information in their record. And so, as I mentioned earlier, the record should always be up to date and reflective of the care provided. And so, failing to document appropriately, can have some very real impacts on individuals and families served. And I'll kind of go through an example of how that comes to play in just a moment. But also what it does is that it leaves the organization vulnerable to accusations around lack of care, lack of timely care, lack of quality service provision. And so again, from an agency perspective, you want to make sure that your agency and the provider is getting credit for all the hard work done. Uh, Let me also say that the lack of timely documentation is one of those first red flags to poor service provision, right? And so, because most of us have heard that saying that if you didn't document it, it didn't happen. Okay, and so let's follow that logic through. So if it didn't happen, then agencies can't be reimbursed appropriately for the service. And so it's a rather simple argument. But again, just a lot of reasons as to why we need to make sure that we are, making sure that our documentation is reflective of the work that we're doing. And also just to note, when I've had this question come to me recently, and so I just want to point it out here, right? When we're talking about, um, accurate and timely documentation, but rest assured that we're not talking about someone who needs to write a dissertation in the record, right? We're not talking about individuals who need to be stellar writers, like, having the ability to write long novels. That's not what we're talking about here. And I know that there have been concerns I've heard concerns during the time of doing this work is like, we want our documentation to be representative of the professionalism that we display when we're doing our role. But I also want to leave you with this, right? That even documentation that has grammatical errors or typos, but describes the work done by the provider at the time that it was done, is still better than no documentation at all. All right. So if that's something, if you're concerned about not being a strong writer, again, supervisors should support this learning, but still, documenting, even if it's not in the best format, is still better than no documentation at all. All right. So becoming proficient in documentation is still, it's again, skill that needs to be taught and practiced. Again, I'll call out our series, the documentation done right workbooks, and I call those workbooks out because they're like a self-paced workbook where you can learn some of those key foundational skills, which you can kind of utilize across a number of environments, but with a focus on what is required from a Medicaid billable perspective. You can spend time doing that on your own and then bringing it in supervision, or vice versa. Supervisors can, assign, specific assignments to supervisees to really help support their learning in that. And then you can review it in supervision. But just to say that individuals do need to be supported in this process. And so I just want to recognize that. So when I talk about, some examples of how when providers fail to document the significant impact that it can have on individuals and how it can be critical, I just want to share this example with you, which in my time of overseeing a behavioral health clinic came up not once, not twice, but multiple times. And so I just kind of want to bring it to life a little bit here. And so I'm going to read this for you. So a young adult who receives services for a mental health condition during a significant time in their childhood is now seeking financial entitlements for which they believe they are eligible given their mental health history. As part of the eligibility process, this individual must obtain supporting documentation of a mental health concern that originated in childhood. Subsequently, the young adult requested their records be released from the treating agency to the requesting agency, but unfortunately, the documentation did not reflect the onset and severity of the individual's conditions, their impairments, and/or their effect on the individual's functional capacity. And so this issue in itself delayed the ability for this young adult to receive the necessary benefits that they would have been entitled to. Um, and so that's, I say this is like that could be the real impact of not getting, of not completing documentation, and not the documentation not being reflective of service provision. Now, this young individual had to seek other means to be able to, get the services that they were entitled to. But when, as a helping professional, you get in this field to really support and help people. And so, it would kind of be sad if for the reason that folks did not document appropriately, that really we disadvantage someone for being able to access what they should be able to access when they needed to access it. So I like to just bring that example forward because I think it's such a critical piece in understanding the human toll sometimes when folks are not documenting accurately. All right. And so, as peer support services expand within the clinic environment, there are some additional considerations for how peer support documentation is written, as this documentation really needs to meet the state's Medicaid program rules, right? And so that's like the second level of it, right? There's the fundamental pieces of documentation, but then transitioning into a clinic format, it's a Medicaid billable service. And so, therefore, documentation needs to support. Medical necessity, which was one of the biggest things, and I know folks have heard that terms, and I'll explain that term shortly. But I think for providers, and this could be for providers alike, right? Not just peer providers, but the focus of this is on peer providers who this may be a new environment for them in delivering the service, and so that's why we're focusing on them. I think one of the biggest hurdles that I've heard about or that I've seen is really in translating the work done by peer providers into statements that reflect medical necessity, and active treatment, and then are coded correctly for the services provided. So what I mean by that is usually when peer providers are out, they're doing the services, where it gets a little complicated, or I think there's probably a little hurdle help that needs to happen here, is being able to say, okay, so what did the peer provider do that really supported medical necessity? And so sometimes there's a little bit of translation that needs to happen there. And as I mentioned, on PeerTac, we're working on some resources that may help providers in understanding that translation. How can we do that a little bit more seamlessly? Um, so I think the biggest keys on this slide is that it has to reflect medical necessity, active treatment. The other pieces are really good foundational concepts to completing documentation, right? So concise, accurate, legible, maintained and available for review, and then coded correctly. So make sure that you're billing for the services that you're actually providing. So those are that. And also, just to mention that there's more than just the provider that's involved in the documentation process. So again, as a reminder, while the agency is responsible for the upkeep of the record, right, it is expected that the individual and the family have an active role in contributing to its contents. So right, so they're a key factor in the documentation process. The provider is a key factor as they're providing services and the one authoring, right? So the responsibility of authoring that in collaboration with the individual is the provider. The provider has a supervisor whose job is to oversee the work done by the provider, and thus they have a role in sometimes reviewing documentation, revising documentation, and all of that. And then overall, the agency has a responsibility for making sure that the providers, the agency understands, has detailed what the standards and expectations are around for documentation, and have developed appropriate training such that their staff are able to implement that, and then also just oversee the quality of service provision within the organization. And then funders, who their job is to manage their dollars and make sure that folks are getting quality services, and that they're getting the services that they need based on assess needs, and what has been identified in the service plan. So right, so there's a whole community here that really is responsible, and being included in the documentation process, right? And everyone plays a different role. All right. So here are some of the fundamentals of quality documentation. I'm just going to walk through this. And again, a lot of these things you can pull forward into services in other areas. But again, the focus here is just remembering that this is a Medicaid billable environment. And so the differences here are going to speak to that. So so the fundamental process, or you heard me say medical necessity, this is a concept you will hear. This is a term in healthcare that really states that the healthcare services rendered are necessary to treat qualified conditions that impair an individual's functioning. And again, this is a standard that is used in all healthcare, not just behavioral healthcare. And so as you're documenting, you will need to be documenting to attend to this as well. And so that may be like one of the areas that is kind of new to peer support service delivery in clinics. So, there will be some strategies to how you wrap in medical necessity as you're working with individuals. The other concept is one of what we call the golden thread. Again, a concept that probably most are familiar with, but really all this says is that it just references the need for all of the documentation in the record to flow, right? To be interrelated or connected and to make sense, to be congruent is the word and term that I like to use, right? So, and that includes the assessment, the service or treatment plan, and then the progress notes, right? So it really is a concept that weaves together all of the critical information and really provides a comprehensive view of the individual. And so the reader of the record, right, should see the logical connection between each piece of documentation, right, beginning with the assessment. We'll walk through these areas, but they should see the connection between what it was the individual came in for services for, how a plan was articulated to support the needs identified, and then how they're doing as the providers are doing interventions, how what progress is being made. And so basically, again, all of that should weave together to make a story that is coherent and makes sense and is congruent. And so that's the concept of the golden thread. And just to say that this is a cyclical process, right? And so you will find that you will this when you're working with individuals, right, you're assessing and recessing needs, and you're making what I call mid-course corrections as things come up. I also want to say that this is not, just to be clear here, this is not a theoretical approach to how you work with individuals, right? But it's how the documentation is completed and aligned to support the care of the individual and or the family. All right. So when we're talking again about the golden thread, we're generally talking about three areas, right? In processes of alignment, assessment, followed by the service plan, followed by then the services are delivered. The progress notes really identify what services were delivered, and then those services get billed and perhaps reported on. And so that's and then you keep going, right? And so if there's a reassessment, then the reassessment happens because there's a new need that you're now aware of as a provider. The treatment plan or service plan is updated, right? Those new services are then delivered, and then those new services are reported on, and then you're billing and reported on accordingly. And so that's the concept when it comes to the golden thread. It really is that it all makes sense, and it all makes sense in documentation. Right, this is a documentation presentation. There's a lot of things happening from a process standpoint. But when we're referencing the golden thread, it is related to how all of the documentation gets captured and tells the story. So that's an important piece. So again, here are the pieces of the golden thread. So it's the assessment, which is the foundation for goal setting and service planning. It's a process that is very dynamic, right? And it changes as you learn more about the family, as you develop therapeutic rapport with the family, and you come to work with them, and you have a better understanding of their needs and strengths. And at times it includes, learning more. About the noted concerns from talking and speaking with others the individuals and families who have identified, who may have some useful and relevant information about the family and their needs. And so all in all, these things are all important to really help the individual or family seeking services, and going to go back to establish medical necessity for the need of services again. So you're trying to figure out how to best support the family, and then how to articulate that in terms of this is services that are needed to mitigate, reduce, eliminate functional challenges with the family or individual. So it is the foundation for goal setting. Next, we have just the service and treatment plan. And again, after the assessment, the next step is to articulate and document what services are going to be rendered to help the individual or family. And then the service or treatment plans includes the goals, right? The goals, the objectives, and the interventions. And that's all laid out in a way that makes sense in terms of what folks what services are needed and how folks are working. And then again, lastly, we talked about this, the progress note, which is really the record of the services provided by the professional, demonstrates the interventions delivered and that they connect back to the established goals and identifies the individual's progress throughout. And so I'm going to share with you in briefly, because I do want to pass this on to my colleague, Maria, to kind of go through the specifics around peer support documentation. But I wanted to share this brief example with you just in terms of bringing, again, highlighting the key around golden thread and just kind of linking it all. And I just want you to see the linkage so that you begin to understand the concept. So also let me be clear that I'm pulling out pieces in each of these stages to highlight the concept in a very succinct manner. And this example is by no way representative of like all the work that it takes to get here to ensure quality service provision, right? So I'm just kind of pulling out some highlights, but just to kind of illustrate all of the points and the congruency. So, so Arlene is someone who came in, noted that she was feeling hopeless, empty, and anxious most of the day, saying she wakes up feeling sad. She sought out services, was assessed to be struggling with depression and generalized anxiety disorder as diagnosed by a licensed professional. During the assessment, it was recommended that Arlene may benefit from peer support services. And so Arlene, they told her that it would be helpful for, could be helpful for her in her recovery journey. And she agreed and decided that would be helpful. So she's going to be working with a New York certified adult peer specialist. There was the treatment team got together, and the treatment team, which included Arlene, included the providers, and also included the peer specialists. They got together to formulate what the treatment plan would be for Arlene. And in clinics, this will be important because as a peer provider, you won't have like your standalone treatment plan. You should be a part of a multidisciplinary team within the clinic, and your feedback should be included in an overall plan for a family or individual, right? So you as a peer provider, you may not be the one authoring the plan, but your input is important to the plan, all right? And then you will also have responsibilities as part of that plan. So, so in this example, I've highlighted here. So the goal here is just to help Arlene improve the ability to manage anxiety, depression, and cope with related stress. And so the one that's going to be relevant to the peer provider here is, over the next 3 months, Arlene is going to learn some new ways of coping with routine stressors to reduce symptoms of anxiety and depression. And this last bullet here, the intervention, which says who's going to be doing what for the peer portion, or for the New York Certified Peer Specialist portion here, they're going to be meeting with Arlene individually each week to really explore what wellness would look like for her, and to begin to take steps to cope with feelings of depression and anxiety. And they're going to use a strengths-based approach and discuss dimensions of wellness. Okay, so that's going to be the peer providers portion of how they're going to be supporting Arlene in her goals. And again, and so for as it relates to the peer provider's way of supporting Arlene around developing her coping skills, when the peer provider meets with Arlene, they're going to be working on that. That's the strategies that they're going to be working on. And so again, not going to read this in its entirety, but I've highlighted some of the kind of some of that translation in terms of how the peer is going to be working with Arlene. So, the peer is going to be listening to Arlene's concerns around In this instance, there's been a recommendation for her to consider medications. And so the peer is going to be listening to her ambivalence around that, right? She's not prepared to make that decision. The peer provider is going to share some personal experience of deciding whether to take medication. So, how that peer overcame that. And let Arlene know that everyone's experience is different with that. But the peer is also going to show Arlene how to research medications and the side effects at reputable sites based on information obtained by the prescribing provider. So she's just going to support her in the learning of that. Additionally, Arlene, she shared that she continues to struggle with learning those coping skills, right? And she consistently feels anxious. The peer provider and Arlene discussed and worked to resolve the barriers to using those coping skills that have been identified to for Arlene to be able to consistently use those to help relieve some of her anxiety. And so they summarized, the key kind of takeaways from the session, and then they completed the note together. And then Arlene, just a note here that she was very engaged in the session and that she would like to make a plan. She says to speak with her clinician and doctor regarding the concerns about, taking medication for symptom reduction. And then next time they meet, the peer provider and Arlene are going to role play how Arlene can, ask her doctor questions about the side effects and the benefits of taking medication, as well as relay her concerns. And so if we go back to just those examples, so that's the connection, right? So Arlene came in, she was assessed to have anxiety and depression. Peer services were recommended to really support Arlene and really just making some informed choices around the care she can access, but also really supporting her, listening to her, and hearing her. And so all of that great work that the peer is doing with the individual needs to get captured in the note. And so all of that, all of the documentation aligns, right? So in this note, you don't hear about them working on something that hasn't been identified in the treatment plan. And so again, that's just an example of what we mean when we say maintaining the golden thread. And here are some common reasons where the golden thread falls short. And again, just to kind of highlight, like progress notes address a variety of issues, none of which have been assessed or identified in the assessment process. Specific interventions used in sessions are not described clearly. From the sample that we just went over, you could see how she was going to be working with Arlene, what they were going to be doing. The goals and objectives are not individualized, or they're not connected to the assessment findings. So there was a goal for Arlene to, reduce her anxiety, and clearly the peer was instrumental in supporting Arlene and being able to do that. So all of that connected. And then when new problems arise, right? Because this doesn't happen all in a vacuum, and it's not a very linear process. And I don't want to give the impression there's lots going on with families. And so, there's a need that, perhaps, you've been working with a family and now a new need emerges. And so now all you have to do is capture that in documentation and circle back around as we talk about the golden thread and the circular process of the golden thread. Doesn't mean you can't address the issue. You should address the issue. That's good care, but make sure it gets translated into documentation. And so that's going to be a key piece. And then the progress note quickly, I'm just going to say that these are the categories I am going to recommend and refer you, and there's a link in this presentation to the official state guidance as it relates to what is required for a progress note. It is laid out there. And so this is kind of what's in regulation. I would say the top two, the plan of action in the next meeting, are best practices and not necessarily written in regulation as you see it here. But demographic information, goals and objectives that are going to be addressed, the interventions provided. You saw a little bit of sampling this in that example that we just went through, and the plan of action. And then I usually say it's always best practice. When's your next meeting? How are you going to follow up with that individual? And so in a Medicaid billable environment, these are things that you're going to need to encapsulate into your note. And so while it looks like there's a lot of boxes here, let me also say that this is probably you could do this in paragraph, right? You saw the note that we just had for Arlene. It doesn't have to be 5 pages long. Actually, I would encourage you for it not to be that. You're going to pick up the highlights, the key points, and you're going to translate that into the note. And again, supervisors can support in helping providers discriminate between what is actually needed in the note and what's just extra information. And with that, I want to turn it over to wait, I have a couple other sections. My apologies. Let me just get through this really quickly. In terms of characteristics for quality documentation, we talked a lot about these, which is, we want to make sure that our notes are done in a timely fashion, that they're accurate, that they're accurate, that they're timely. And so here's just some fundamentals around note writing. Um, One of the things is that you should just include the facts, right? Firsthand direct knowledge. Leave your speculations and judgments out of notes. Include the fact. If you saw it, if you witnessed it, include it in the note. If you just have some suspicion, maybe not, you should, if you need to write it in the note, because sometimes you need to note that it is suspicion and not verified. Remember, these records follow people from all over, and so you don't want to be putting things in records that are not accurate. And if there's errors in the notes, just make sure you go back. A lot of you, if you're utilizing an EHR record, you can go back and redact the note to make sure that it's correct. And sometimes just note the reason as to why you needed to redact it. Again, ensure the record is completing information as timely as possible, putting it in the file, making sure it's there, any supporting documentation that you're utilizing to determine care. So if you're utilizing, a common thing that maybe folks utilize is like a report from a psychiatrist, from a previous psychiatrist outside of your organization, and you're utilizing just say the diagnosis over that, like you're writing based on that, individual diagnosed with depression. Obviously, if you're a peer provider, that's not within your scope of practice. So you would want to say, individual diagnosed with depression as referenced in this document, or as referenced by this provider. So it's clear that it's not you who's making that determination. So you want to make sure that that's clear. You want to make sure that you are doing work within your scope of practice, and so again, I'm going to refer you to the guidance document to be clear about what it is that falls under peer support service delivery. Remember to sign and date your notes. Good thing is, like a lot of EHRs, you have to do this, but a note is not a service. Let me see. A service is not billable if the progress note is not signed and dated by the provider. So just make sure you're doing that. You want to make sure that your information, again, this kind of goes back to just in not putting a lot of speculations, assumptions. Don't put irrelevant information. Not all information is information that needs to be put in a note. And once you learn those categories that we talked about, the progress note, that will help you zone in on the important information that needs to be included in notes, right? But the neighbor came over to say hi, and or the neighbor's smoking weed, if that has nothing to do with the care provided to that individual, then it doesn't need to be in a note. All right. And you also don't need to capture play-by-plays in notes, which can lead to very lengthy notes, like saying like, I arrived to the house, I knocked on the door, I went in, I sat on the couch. Like all of that is just noise. You don't need that. In note writing, and it actually will just it'll just take you longer to write the note, which you don't want to do. And of course, it should just be legible. People should be able to read it. Acronyms is we talk in a lot of acronyms, but honestly, in abbreviations, unless they're like universal, you should really try to avoid them, because people coming behind you reading that note, let's just say 10 years later, and they're looking at their note and you have a whole lot of acronyms in there that no one knows what they mean. So you should really try to avoid that as much as possible. And just again, and I mentioned this, that grammar, it is important, right? Because it professionalizes the note. But again, this is you don't have needed to win, a prize for great writing. And actually, poor writing is better than no writing. So I just think we should just keep that in mind. But if someone is not a great writer, so you want to make sure you're working with them to improve that skill. as it relates to documentation, which is a little bit different writing than, like, again, if you're writing a narrative or a story or something like that. So that's important to say. And then notes should just be timely. They should be written as close to the event as possible. It's good practice not to really allow extensive periods of time to transpire between the time the event happened and the note, in part because you don't always remember the details, especially if you're seeing a number of individuals back to back, or if you're in the field and you're, by the time the day has ended, you've seen 5 or 6 people. It's really hard to remember the pertinent details across all of that. And if your notes are ever subpoenaed in a court environment, they will pay attention to that. That will be paid attention to. Like, if you're writing the note 2 weeks later, how is that note accurate? How can you substantiate that that note is accurate? So that's just an important piece to remember. And so just to leave you here with, think about how accurate the record is if the documentation is not completed as close to the event as possible, right? So how accurate is that? How available is the record if the information is not current and up to date? And how reflective is the record if the required documentation is not completed with the participants' input as well? So I just want to leave you with that before I turn it over to my colleague to walk us through the rest of the presentation.
Thank you so much, Yvette. That was super informational. So hi, everybody. Again, my name is Maria Fuentes. Everybody's able to hear me okay, right? We're good. I saw some questions on the chat, and I am going to touch on a lot of the information that you guys came here to hear about peer documentation. We want to talk about it, but we also want to emphasize that the information Yvette provided is foundational, right? In order to have a Medicaid billable note, these are things that we need to know. I understand this is a little uncomfortable. It's not something we're used to it, or that we came into this profession knowing how to document, right? But it is something that we can learn. It is a skill that is very important that we can learn and put to practice. And along with that, we are going to learn how to use this along our peer values, using person-centered language, understanding how this fits into our code of ethics as peers. And if anything is not clear, feel free to talk to your supervisor. Use supervision for this to be able to practice this and do, again, it's not something that comes very easy. It's not easy for everybody, for anybody. A lot of people don't like documentation, and it's fair to say it does take practice, but it is a skill that we can learn. Okay, so supporting peer support services delivery and documentation. So what is it that we're looking for? The peer support core principles. We are looking for it to reflect that it is recovery oriented, right? The peers partner with people they serve to support them with hope and building on strengths, walking along with people, recognizing that there are multiple pathways to recovery. It is also important that it is person-centered, as I mentioned before. Peers are always directed by the person receiving services. It is a personalized service with the needs of the person being served as they, the person that we're serving, identify them. It is voluntary. Peer workers work as partners or consultants to those they serve. They do not dictate services to the person we are working with, right? It's not dictated. And that's something that came on the chat as well. Services are always a choice from the person or as a request. So that's something important to highlight. It is relationship focused, and relationship is a foundation to peer recovery support services. It is important to highlight that peer work is respectful, trusting, empathetic, collaborative, and mutual. It is also trauma-informed. Peer work utilizes a strength-based framework, which emphasizes physical, psychological, and emotional safety for the person to rebuild a sense of control and empowerment. So those are things that we can definitely add on our notes. Now, I might, oh, did I go too far? Sorry about that. Okay. Supporting peer support delivery and documentation. So what are we trying to demonstrate when we're writing these notes? There has to be a focus on recovery and resiliency, right? We emphasize that because we are peers working with people. It is important that the activities that support the core principles of peer support, such as empowerment, hope, voice, and choice, personal or family center, culturally and linguistically responsive, and community-based are highlighted. Making sure the support that is based on shared lived experience. That's something that peers bring to the table, right? That's something we work with. The evident collaboration with other service providers, highlighting safety planning and care coordination tasks. So what do we do with that? We are part of that team. We are part of the team with the clinician, the psychiatrist, whoever else it is. And we have to make sure that we notate, we write our notes showing that collaboration and how that links to the goals and the services that we're providing to people. And lastly, identification and connection with formal and informal supports as needed in our or as requested by the person or persons. So if there's anything outside of that multidisciplinary team, we have to be able to write it down and we have to know how to do that. And again, we can always use supervision to come back to that and find out how can we best document that information. We use human experience language, which is a very important skill and is a challenging one. Peers can often fall into what I call the code switch trap, since we have been through so many systems and we learn the language to be able to communicate and advocate for ourselves or for our loved ones. It's very important to note that we're not clinical workers. That is something else that came on the chat, right? We don't do clinical work, but we can talk and we understand the language. We know what it means. So if we're able to use, and we will be sharing some resources for this as well, like sentence starters and other things like that, for you to be able to know a little bit more, how can you put that into play? Also, we are using the person's words, their terms, their preferred names and pronouns, remaining respectful of their culture and customs. Peers can explore what does this look like for that person, right? What are they comfortable with or not? What is core value language? Are you familiar with it? Is your supervisor familiar with it? Is this something that you both can learn together, right? Using strength-based language, person-first language. For example, Gabby shared with me that she felt comfortable being an advocate for her child. Gabby is empowered to help make changes for this for her child. You know, things that she told me this, she told me that, like making sure that the goals connect with the services, right? What is it that we're going to do together to be able to, what am I going to do as a provider, as the peer, to be able to support Gabby, to be able to advocate for her child, right? How am I using my live experience to be able to support this person? And last but not least, review strength-based language. We have definitely a cheat sheet for that. So we are going to share some awesome resources with you soon. Um, Peer service delivery. Okay, so let's remember this about peer service delivery. They can be delivered before admission happens. Peer support services have no limit as long as the goal is identified and documented. Peer services before admission can only be individual, not as a group. Each contact must be documented, including purpose, response, and progress made towards the goal, right? I know it sounds very clinical. And once you put those things together and you understand what is the purpose of us meeting, right? How did this person respond to that?
Thank you so much for your help.
You're welcome. Have a good day.
Thank you,
Sorry.
Maurice. Can we just ask for folks to mute on the phone? Thank you.
Thank you so much. A pre-admission documentation must be signed by the peer and practitioner working with the person receiving services. That is something that Yvette added before, right? Let's make sure that everything is accurately. Again, we are working with Medicaid billables, so we have to follow certain rules. The foundation that Yvette talked about before adds on to that, um, and then we bring our peer lens into it, right? Admission is not required to bill for peer services. However, if the person declines treatment and does not enroll in the clinic peer services, the services cannot continue. This is guidance from OMH, so definitely something that your clinics have access to, and you guys are able to talk about these things or this, however this looks like in your clinic, within your clinic, right? And how you guys work it out. There are also some considerations when providing peer services. That's the next one. Workflow. What does it look like? Do you guys have an idea of what that looks like? Are you able to capture the delivery of peer support services through that workflow? If it's not working for whatever reason and something needs to be changed, everybody can collaborate into making these changes, right? Revise it, go back to it, work with it and see what works best for you guys. If peer feedback is not being included and documented in peer services, ask yourself what is missing and how can we integrate that, right? How are we able to talk about those things? And, are we really being collaborative when we're doing this work? It's very important. You can use supervision for that. You can definitely learn together as you go along. Is there training available for peers to learn about documentation and how to do this? The training that was mentioned before, documentation done right, is something that I used when I was providing services in a mental health school-based clinic. And it was actually very helpful because I learned a foundation which actually supported me into doing the work. I didn't know there's other extra wonderful things that I learned here, but it kind of made sense, right? That there is a way to document so Medicaid is able to pay for those services. Also, and this is the biggest thing, that we're being respectful of when we're documenting, we're being respectful of the person. We're telling their story. We're narrating how is it that we are supporting them, but how is it that they're growing when they're with us, right? What's happening? And if like nothing is perfect, right? Life happens. So they regress, they go back, things happen, they go right back to square one. That's okay. We have to document that as well. And it is part of life. So it doesn't have to be linear. It doesn't have to be something that follows a pattern. But it does have to be documented however it happens. That is very important. Another thing is, how long do peers have weekly to complete paperwork? You guys have a plan on that? Do you need to make a plan on that? I know that was on the poll that came up as something, right? Um, just having a designated little time every day or maybe every week to be able to do your paperwork. It's important. Time management for documentation, providing services to people. This is a skill that some peers have, right? And some peers need support building it, and it's fair. It's the same thing with clinicians. There are clinicians that are amazing at documenting, and there are others that feel very uncomfortable with it. And it's fair to say, it depends on the person, but we can learn these skills. Supervision, again, can also be a great space to build those skills. So use it very wisely. And who is overseeing these processes that are being put in place? Is there somebody overseeing the overseer? Very important. Sometimes we need feedback from one another. Sometimes we get too caught up into what we're doing and we think is right. But are we really collaborating into making a better space for everybody to work together and be able to understand that these things might be a little bit different? But peer support is a profession. So now we are definitely bringing our lens into it, right? And maybe we know more than our supervisors, and it's fair to say we can still collaborate into knowing how to put those pieces together. Lastly, how will the supervision process be documented? So make sure that those things are, available and they're out in the open to talk about when it comes to peer service delivery. Now, I want to invite you to meet Drew. So I'm going to give you a scenario and I'm going to ask you to answer a poll after this, okay? Because here's where person-centered language comes in. So meet Drew. Drew is an addict that began using drugs and alcohol around 12 years old. Drew was manipulative and a real party animal. The addict hit rock bottom and even cut the wrist. The cutter was out of control and placed in rehab at age 13. Drew's mother was unfit, and so the addict emancipated themselves at age 14 from her and abused the system. Okay. So now the poll. I would like to know, what impression do you have of Drew from reading this note? If you were to read this note, how would you feel about him? He's dysfunctional, he's bright and intelligent, he's out of control, he's trouble, he's capable. What do you guys see? I give you a couple of minutes. Yeah, mostly everybody sees troubled, dysfunctional. Very few people see here capable, bright, or intelligent. So that's really interesting. All right. So I'm going to end the poll now and I'm going to share the results. And so majority of people saw Drew as trouble, dysfunctional, some out of control and capable, about the same. And very few people saw him as bright and intelligent. All right. So now I'm going to read you another note. And now I want you to meet Barry. Barry is a person that has a substance use disorder. Barry is a resourceful and talented actor that began their career at 11 months old. Their mother took them to many parties, and Barry was exposed to substances at a young age. After a couple of years, Barry couldn't successfully cope with their substance use disorder and needed treatment, which they received. Barry's mother was experiencing barriers to successful parenting. Barry decided to emancipate themselves at age 14, as that decision seemed to be self-advocating for their best choice for recovery. Now I'm going to share the poll. How do you see Barry from reading this note? It's the same choices: dysfunctional, bright, intelligent, out of control, trouble, capable. Give you guys a minute to answer that. Okay. Capable. Yes. Bright, intelligent. That's the majority. Awesome. All right. So we have, I'll share the results. We have mostly capable, bright and intelligent. Very few people thought of Barry as trouble or out of control or dysfunctional, right? So there, with that example, you can understand the importance of how we document. the importance of how we use these words and how we describe people and their story. We are responsible to tell a story about the people that we're working with and how our live experience links with those with that, right? So more than documenting because it seems like boxy, right? It has to fit in this box. Let's document to respectfully tell somebody's story, which is what we're here to do as peers. All right. This is another thing that came up before. Peer support versus clinical notes. So now let's look at the difference between peer support notes and clinical notes. Peer support notes do clinical, peer support notes use language of ordinary human experience. They focus on recovery and resilience. They include the person's strengths. They use the person's goals for recovery, and it is all about that person. Clinical notes, they use clinical language such as diagnosis, symptoms, medications. It focuses on symptoms management. It identifies challenges to be addressed, explores root causes of current challenges. It provides recommendations for services. So I want to highlight that they're both important. It is very important to know this information, right? So a clinician do their work and they're able to input their information for how they're able to provide the services to the family or to the person. How we do it is this is the difference, right? We are able to write about the person. They're writing about what's going on with the person from a clinical point of view. Both of these notes are very important. Both of them are important. So when we collaboratively work with a clinician, we work with another provider and we're both providing services to this person, we can see this person from two different lenses. And it's important to talk about those things, right? Being able to have that conversation with the provider and say, I need to let you know how I'm seeing this person, or are you seeing this person from a negative point of view, as we saw Drew and Barry, because things are being said differently, right? So we will be sharing some resources with you guys, add into that. Now I want to go really quick. No, sorry, Yvette provided us that information. So supporting peer support services delivery and documentation consistently links back to the peer support provider's purpose and role. It connects to the individual's stated goals, such as the person request. Remember, person center. Define life goals, objectives the person needs to achieve to be a valued community participant. They have to live in the community. So, we have to make sure that we're talking about those things with the family so we can provide the supports that they need. How do we document that? We write it down. That's pretty much it. Find what makes sense. And again, the resources will be super helpful for you. Trust me, we've been working really hard on this. Define desired changes in terms of specific observable behaviors. It captures strategic sharing of lived experience, details steps in navigating various systems to assist the person of the family in accessing supports, which is something that we also do, right? We provide the support and the guidance, and we walk along with people. That is very important. Reflect support in decision-making, problem-solving, advocacy, skill development, and community connections. Identify strengths, capabilities, interests, preferences, needs, hopes, dreams, priorities. These are the things people are talking to us about. We're peers. That's what we're doing, right? They're telling us this stuff, and that's important. Address willingness and motivation to invest in recovery. Charts each person's recovery journey and provides an opportunity to reflect on success, accomplishment, and lessons learned. So we are able to bring that back to them. Now, how does the golden thread apply to peer documentation? So again, we have to be able to connect their recovery goals to every service that we're offering within the agency, right? So why are we doing this? Why is the golden thread so, it is so out there, right? Like, sounds so clinical, but it really isn't. We need to be able to do this. If somebody comes for an audit, they'll be able to see clear notes, things that make sense, things that follow a pattern or not, but they follow a pattern in a way that it makes sense to either the recovery or of the person or whatever that person is going through at that moment. And that is important, that we can narrate that to the best of our ability. Some common progress note errors. These are things that happen, right? Writing lengthy notes, writing every single word the person tells us because we think that it's important. I'm not gonna deny some of it is like very hard to put aside, right? We want to tell the whole story of what happened during that session, during that one-on-one with the person or the family that we're working with. But again, we can use supervision to be able to take away and kind of help the supervisor is able to help connect those dots, right? Because they've been doing this for a long time, so they know how to do that in a different way, but with our language, with our person-centered language, with our sentences, we're our way of narrating things. Recording irrelevant details, Yvette talked about that a little bit. Saying things that have nothing to do with the service or with what's going on, including a play-by-play of the session, not necessary. The one-on-one doesn't have to be thoroughly described. Not connecting goals and services, that's huge. And again, it is a skill that we can learn how to do. Sometimes using judgmental language, it's very, very hard. Especially we are working through our live experience, and sometimes our trauma gets activated through these things, right? We're working with families that have gone through what we have gone through. So making sure that we can put those things aside. If there are any biases that we have, we all do. We all do. So how are we able to put those aside, and how we're able to use supervision to put those things and kind of like set them up where they need to be. Lastly, a few things to check before submitting a progress note. Is it written in complete sentences? Does it not use acronyms? Let's make sure we emphasize on all of these things. This is very, very important, right? And this is part of our resources that we are going to share with you and give you a lot more information on. But does it explain how are you working with this family, right? How does this benefit? How you working with this person is benefiting them or helping them or supporting them? How is the helping with this family doing the same thing, right? It include that there, because when we're family peer advocates, we are working with the parents to benefit the children. So that's something to highlight when we're writing our notes as well. Include whatever you have seen, not what somebody told you or what you perceive that might happen. Also document the perspective or of the person that you're working with. Make sure that you guys are working together and that you're able to write that note together, if at all. And you're able to use their words and use some quotation marks on some things of some phrases that they have said that you might deem important. Plan what's going to happen next, right? What are we doing? How long do you think this is going to take? How long are you thinking that you're going to need to be able to do that? Like, let's be realistic about this, and you tell me what works for you. When are you meeting again, right? It's important to know. Using person first, respectful, non-stigmatizing, non-judgmental language. We have to emphasize that. Again, I hope this was helpful. We will be sharing a lot of resources with you guys, so you guys could give us a little feedback on that. And it was a pleasure. Yvette?
Yeah, thank you, Maria. Thank you. Listen, I love the questions coming in the chat. I just want to comment on a couple things, and then I'll walk through my last final slides. So let me just say this. Yes, peer services are not clinical services, right? but they will support clinical goals in the clinic, right? They're not clinical services, but they will support clinical goals. And so a little bit of that, and that's that translation I was talking to, is utilizing what you're doing and translating that back to how is that getting reflected for medical necessity. And so that's different. That's a little bit different, which is why I was pointing out. But I do want to say, I don't want to give anyone the impression that they have to write clinical goals, that you do not have to do that. And in terms of language, use plain language, right? Use the language that you use, as Maria just went through and talked about. What should also come through the note is your lived experience, all of the breadth of experience that you're bringing and how you're utilizing that lived experience to support individuals. All of that should shine through in your documentation. So, I kind of walk through some of the fundamentals, because when you move peer services into clinic services, these, again, if we go back to the beginning of the presentation, in order for it to be Medicaid billable, you have to demonstrate these things. And so the key here is just being able to translate all of what you do into a way that is billable. But that doesn't mean that we expect you to, learn how to write clinical notes and do all of that. Some of the things that I showed you too, remember, you're going to be part of a team. You may not necessarily be authoring, for instance, you may not necessarily be authoring the treatment plan, but contributing to it, right? But you will be authoring your progress note. If you're working with an individual, you will be authoring that and signing off on your note. So it's gonna be important for you to understand what exactly needs to be submitted in that note. So I just kind of wanted to comment on that. And I think what we're trying to get across is we want peer values to shine through in the documentation, right? That's what we want. But in order to do that, I think you have to have some foundational understanding around how all of that connects. So thank you all for the comments. They're just very helpful. And again, as Maria said, we'll be sharing some additional resources. I'm going to go back in the last couple of minutes. I am going to take questions, so I'm not going to spend too much time on this, because these are just slides that when you get the deck, you can read through. But here's the point of these slides. And I said it at the beginning, documentation, this is a skill that has to be practiced. This is a skill that requires that folks know what the expectations are around documentation, right? That they have practice at it. That when you're submitting notes and you're not clear about what needs to be in them, that your supervisor's giving you feedback and input, like, too much information here, not enough information here, that you have time to understand that and be able to do that, right? So you got to make sure you get training. And again, we'll have some resources for you. You have to, as a supervisor, and even, as a peers, you're doing this work, maybe you could reach out and find someone who kind of is versed in this to kind of help you if you find yourself struggling. In clinic settings, diagnosis is required. You are not the one making the diagnosis as a peer provider, but your work is supporting kind of a remediation or support of that, along with some other things. So it's just language to be mindful of. You always want to make sure that you're tying your work back to relevant goals and objectives, right? And there's a number of things that you guys have the ability to do under the scope of peer support services. Just make sure you're linking that back to the individual or family's goals. That's the key there. I think Maria talked about that. If there's again, if you're a supervisor and you're working with peers, really support them in this process. Again, especially as we transition into the clinic role and environment. Utilize supervision time to write notes together. I think the best learning around this is when folks, if you want to know what should go in and out of your notes, you send it around for review and let people kind of help and support you in that. And then you can learn that. The key to doing all of this is that you don't want documentation being the sole, kind of being what you're doing the most while you're trying to do this work. You want to do this work. You just want the documentation to reflect the great work that you did. And so the strategies are around like knowing what it is that you need to document, being able to do that in a very succinct way. And then in Yvette's world, that's 5 to 10 minutes when you get really good at this. When you're first starting out, it'll take a little longer until you get into the hang of it. But you don't want that kind of being what's what has you kind of not liking the job and the roles, because you're spending too much time doing documentation, right? So really what you want the documentation to do is to shine for all of the work that you are doing. And so we're kind of trying to turn the tide there to help you understand. And again, if this doesn't happen overnight, this is months long process, could take a couple months for you to learn the skill, could take a year, but you should, you have to practice it. Don't work on everything all at once. Work on one aspect of something that you may need to improve. Like, so maybe the aspect is, I just need to figure out what needs to go in, right? I'm putting too much in. I need to kind of figure out what needs to go in, what needs to stay out. Work on that. When you get a good handle on that, move on to another skill that you think you need some support in. So again, all ways to strengthen documentation, create a peer-to-peer support system. Again, just, are there others that you can reach out to? Create a plan for doing your documentation, catching up if you need them. I think use supervision time to review documentation. If you're unclear about what needs to happen, use your supervision time for that. And then again, as a supervisors, the role model that habit as well. And as a supervisor, if you're unclear about documentation requirements, then you yourself need to get training so that you can relay it to your staff. And so those are just some strategies for strengthening these practices. And so we do have a couple minutes, and I do want to entertain any other questions that I didn't answer in my kind of looking through them. Please feel free to unmute if you have a burning question that you want to ask us. Otherwise, we'll do our best to just kind of quickly check. And I'll ask my colleagues if there's anything that they came across that I didn't respond to.
Yvette, some of the peers want to know if there are CEUs for FPA or YPA for this training.
That's a good question. So I would say you probably have to submit. I know that they're pretty light. You probably just have to submit to them. I can check in with them and we can follow up. But usually what happens is you just submit that you did this training, and they'll count it if they feel it falls within the realm of counting. So thank you for that, Maria. All right. Did I miss any other questions that I missed?
Yvette, I just had one on core, but I don't know
Yeah.
if it applies. If a client is going through core and they're not currently enrolled with a 31 or 32 clinic, is the rules still apply where they could not be engaged with the peer long-term because they're not going to follow through?
Oh, that's a good question. I'm not sure about that question. I'll have to get
Okay.
back to you related to core. Yep,
Okay.
absolutely. Stephanie, I see you have you have your hand up.
Yeah, thank you so much. And thank you so much for this presentation, this training. It was awesome. But at this point, I kind of feel like I've never written a decent note, in the years I've been doing this right now. But it's okay. But I did have a question, because when it comes to working with mental health clients, um, things change so frequently.
They
the
do.
goals changed and things changed, and trying to stay on top of this, and one day you may just, have a session with someone, and they just want to talk about like their trauma that's happened to them, in the past, and it just came out of nowhere. It doesn't relate to a goal. It doesn't relate to anything. But, I kind of feel like, based on what I've heard today, like that's not pertinent information to have there, but it's pertinent information to be in a note somewhere. So
Correct.
like, how do situations like that play out?
Yeah, and so that's a good point, because this is a very dynamic process, right? And so in that circumstance, let's use that example. It probably does make sense to note after your work on your goal, whatever, to note in the note, client or, individual discuss that, this issue, came up and is impacting their ability to do something, right? A provider will continue to assess the impact of this on functioning. And then if it's such that it needs to be included in a treatment plan, then you go back through that loop, that reassessment piece, and add it to the treatment plan. Yes.
Thank
So
you so much.
I hope that's helpful, right?
It was
I know
very helpful. And
Yeah.
Maria is gonna, take some time to think about everything that we've talked about and come back and kind of make our life easier with questions like that. Thank you, Maria.
You are
Absolutely.
most welcome.
Absolutely. We have a couple more hands. I do have a couple extra minutes. I'm happy to stay. I know the folks, if you have to hop off, feel free, but I can stay on for just a couple more minutes. Maybe I'll just take the questions. Folks who have their hands raised.
Yes, thank you so much for this presentation. My name is Chanel and I'm from Connect at Henry Street Settlement. I had a question about peer-specific screening tools. My apologies if I missed your feedback on that, but are there any documents that we can take on for our peer as she engages in screening?
A specific tool. We don't have a specific tool at this time where, that usually is organizational, like dependent on terms of how the mental health clinic might want you to be, screening. And I say screening, and I'm using that loosely because sometimes there's this debate as to whether or not peers will do some screening. But let's just say they're going to be meeting with someone and they really want to assess wellness, how that person is doing, how that person is functioning. So usually that is organization dependent. We don't have like a tool that we would say, all folks should use this particular tool in doing that.
Excellent. Thank you so much for that. Thank you for your time.
Yep. Thank you. And is it Leanna?
Yes.
Okay.
So, hi, Yvette. You guys
Hello.
are absolutely amazing. I love the work that you're doing. I like how detailed you guys broke it down. So it's kind of, it seems like a lot, but once we start doing that on and on, we'll get better at it. And you're right. It may take about 5, 10, 15 minutes to write a note. And that's a good thing. I currently do work with 1 or 2 families, but most of the people that I do work with as a family peer support are people who are just receiving clinical services for mental health. And what I find, especially with adults, is that it's very hard to get them to stay on task, right? Like this is so each week when I meet them, it always seems like we're starting from zero, So, but the one thing that I do know is that they do have goals and objectives written in the treatment plan, right? And so how do because somebody else asked about it. I can't remember who it is, and I don't see her right here, but someone else has asked about it. Like if like you can speak with somebody in a session, and we can try to talk about the goals, but then they just want to talk about their trauma, and that's really where they're at on that day. So tying all of that into what we're doing. Is it possible to say something like, client, client spoke about ABCD. Client is having a difficult time moving past this point. I try to redirect them to back on track to the goals at hand. We'll start discussed with client. We'll start working on steps once again. Would that be something like, just to kind of tie it into and bring it back to, we're still doing what we need to do, but it may take a little longer.
Yeah. Yes. So quickly. So what I said earlier is like, we always just want the documentation to be reflective of the work that we're doing. Right. So if there is this significant, if it's relevant to how the individual is functioning, right. So, we're supposed to be working on anger and depression, but I get there, they have a financial crisis. They're getting ready to be homeless. Now that's going to take precedent. Right. And so they can't think about either anxiety and depression are working on any strategies right now because they're worried about what they're going to do today because they're getting kicked out, right? So that's relevant, right, to their functional status. So you can't just overlook that and be like, oh, well, great, sorry, you're going to be homeless tomorrow, but let's talk about these strategies you're supposed to be learning. That's not going to work, right? And so what you what you say is like, arrived to work with the individual around this. An individual informed me there was, an issue that needed to be attended to. Here's how I supported that individual. Here's how we'll pick up. Here's the next steps. All of that is fair game. So again,
Okay.
relevant to the care provided and relevant to the status of how that individual is functioning. If you find yourself doing that several times in a row, and I know we're running out of time, but if you find yourself every time you go there, there's a new issue, and you should, that needs to be addressed at a larger perspective, and perhaps that's a treatment team, get the treatment team together. Let's talk about every time we go to this, that we meet with this individual, there's a crisis going on. Let's talk about how we can best support them.
Right.
So, yeah. Thank you all. I know we didn't get to all of the questions, but our contact information is on the slides. To let my colleagues go. I'm sure they have other meetings, but our contact information is on the slides. Let us know. Peer, we have info@peertech.org. You can email us. I will respond to any document. Myself and Maria will respond to any more documentation questions that you have. So please feel free to do that. We enjoyed having all of you, and hopefully you'll hear from us soon again. Thank you all.
Thank you.